Yeah, so a great question. So sotagliflozin is the newest FDA-approved SGLT1 and 2 inhibitor. So it's a dual inhibitor. So the labeled indication of sotagliflozin is to reduce cardiovascular death, heart failure hospitalizations, and urgent heart failure visits among patients with either heart failure or patients with chronic kidney disease, type 2 diabetes, and another cardiovascular risk factor. So really those two indications. And this FDA indication was based on two real pivotal clinical trials. The first was the Soloist WHF trial, which is among patients with type 2 diabetes that were hospitalized for worsening heart failure, regardless of ejection fraction. It was an overwhelmingly positive clinical trial for that primary endpoint. And then also they had the SCORED trial, which is a patient population of patients with type 2 diabetes and chronic kidney disease. And again, overwhelmingly positive clinical trial. So putting those two clinical trials together, that supports the FDA labeled indications for this therapy. So it's a combination SGLT1 and 2 inhibitor, which is a little different than some of the other therapies that are approved, which are more just SGLT2 inhibitors. But to be totally clear on this, there's no head-to-head trials of sotagliflozin versus the other SGLT2 inhibitors. So we don't really know comparatively how well they work compared to each other. But we do know that it seems like this class of medications, and now we have three FDA-approved medications in this class for treatment of heart failure, they all have really overwhelming clinical benefit for patients with heart failure, really across the spectrum of ejection fraction. And when the totality of evidence is put together, it really supports this class of medication as a mortality reducing, heart failure hospitalization reducing, and quality of life improving class of therapy. And this class of therapy has a class 1 indication for patients with heart failure with reduced ejection fraction. It's also recommended at really the top of the algorithm and expert consensus for patients with heart failure with an ejection fraction greater than 40%. So really it is a foundational therapy across the entire spectrum of ejection fraction. And we're happy to have, sotagliflozin as a really valuable weapon to combat heart failure. Yeah, so in the SCORED trial, the overall results, so this was an overwhelmingly positive clinical trial, sotagliflozin versus placebo among this diabetic CKD patient population. There's approximately about a 25% reduction for that primary endpoint of CV death, heart failure hospitalizations, urgent heart failure visits. The curves kept separating over time. They separated rather early, but they kept separating over time. So theoretically, it seems like this benefit kept growing. But to get to the fact of the early separation event curve, which is something that I think is very clinically relevant, and we've seen really across all the different SGLT inhibitor trials, is by day 90 to 95, you had statistical significance achieved for that primary endpoint. And you also had statistical significance achieved for the MACE endpoint. This was one of the secondary endpoints that was presented at the American Heart Meeting, where they looked at the timing of the MACE benefit to hit statistical significance. So again, it just shows that you have an overwhelmingly effective therapy, but also that we need to start this therapy right away, because even delays of a few months are needlessly exposing a very high-risk patient population to excess clinical risk. And this is something that we've seen really across the spectrum of the SGLT inhibitor trials, that again, very early separation of event curves, and again, delays equal needless exposure to excess risk.